Good afternoon, everyone. My name is Carrie McDermott, and I am the Communications Director with the Great Plains Quality Innovation Network. We are the quality improvement organization for North Dakota and South Dakota. Before we begin, just a few housekeeping items. We are recording today's session. We will send it to all of you within 1 to 2 days once we have a chance to add it to our website, which will be at greatplainsquin.org. All lines are muted at this time so we can allow our presenters to present, but don't be shy. Feel free to add questions into the chat or comments if you have any throughout today's session. And if you do have questions for any of our presenters, we'll address them at the end of today's session. Today's conversation is titled "It's All About the Heart: Opportunities for Cardiac Care in the Dakotas." And we're going to highlight the importance of cardiac rehab services in the Dakotas, the availability of cardiac rehab services in the Dakotas, challenges with utilization, and opportunities to get connected and involved. It's February's Heart Awareness Month, and so it's especially timely. And I'm excited to hear from my colleagues, both Dee Kaiser and Stephanie Hansen, who has pre-recorded her presentation today, and then as well as Tim Nicolai, who is the Senior Rural Health Director for the American Heart Association. So Dee, if you're ready, I'll turn it over to you to begin today's presentation.
All right. Well, thank you, Carrie. As Carrie said, I am Dee Kaiser. I'm an RN and a Quality Improvement Advisor with Great Plains Quin. And today we're going to review the landscape of cardiac rehab in the Dakotas, or CR, as I will refer to it throughout the presentation. We're also going to hear about cardiac-ready communities and learn about the Outpace CVD, which is a quality improvement program to improve outcomes of cardiovascular disease from the American Heart Association. So let's get started. Before I talk about the results of an environmental scan that GP Quinn conducted, I want to give an overview of CR and then talk about the data in this infographic. We know that heart disease is the leading cause of death in the US, but strong evidence shows that cardiac rehab following a cardiac event can significantly improve functional status and quality of life and reduce mortality. In fact, heart disease remains a leading cause of death in many ethnic minority communities, with African Americans, Hispanics, and Native Americans experiencing higher rates of cardiovascular issues than their white peers. In addition, claims data on multi-visit patients in the Dakotas with fee-for-service Medicare who were admitted or readmitted to the ED, observation, and/or inpatient stays shows that a cardiac diagnosis was listed as the primary or secondary diagnosis on a Medicare claim. After removing behavioral and alcohol substance use diagnoses, about 10% of the time, a cardiac diagnosis was primary or it was secondary 16 to 22% of the time. And we're going to have links, yep, I see they're already in chat, where you can find more information on the multi-visit patients on our website. So I would definitely check that out. It's very interesting. Of course, we want people to seek emergency attention when experiencing a cardiac event, but referring and encouraging patients to participate in a cardiac rehab program may help decrease readmissions to healthcare facilities following a cardiac event. Now let's turn our attention to the infographic on this slide. It's from Million Hearts and outlines cardiac rehab's enrollment, engagement, and completion among Medicare fee-for-service beneficiaries aged 65 and over who had a primary qualifying event in 2017 and were eligible to participate in CR and bill Medicare. So a qualifying event includes hospitalization for acute myocardial infarction, or an MI, coronary artery bypass graft, or a CABG surgery, heart valve repair or replacement, percutaneous coronary intervention, or heart-lung transplant. So I do want you to note that this data is for original Medicare, also called fee-for-service Medicare, and the beneficiaries in this data are age 65 and older and had a cardiac qualifying event that made them eligible to attend cardiac rehab in 2017. So details of this infographic show the percentages of patients who initiated or attended sessions. So we can see that 23% of patients attended up to 12 sessions or more within 90 days after a cardiac event. 17% of patients attended up to 24 sessions or more within 180 days of a cardiac event. 8% of patients attended up to 36 sessions, which is considered to be a full dose of CR within 180 days of a cardiac event. And then we also see down at the bottom the enrollment rates by sex. 3 men to 2 women initiated CR sessions. And if you look at the race and ethnicity, 2 non-Hispanic white people to 1 non-Hispanic Black person initiated CR sessions. Since this data is from 2017, it does not show the effect that the COVID pandemic had on utilization rates, but we do know that in 2020, the rates were 0. The pandemic did bring out some innovative ways to do CR, such as by telehealth and having remote CR staff monitoring vitals of the participants while they exercised. Things that could be continued, especially in the rural areas where access to a program is challenging. So knowing that CR utilization was low nationally, GP Quinn wanted to see what the landscape looked like in the Dakotas. So we initiated an environmental scan and sent out a short survey to all the hospitals across the Dakotas. We had a 91% return rate with the survey. So as you can see, 64 of the 82 did have a cardiac rehab program and 18 of our 82 did not. We also asked in our environmental scan, what phases of cardiac rehab did they offer? So what was reported back to us were phases 1, 2, and 3. And as you can see here, we also dropped pins on the maps for CR programs that were closed. So when we talk about phases, phase 1 of cardiac rehab starts while the person's in the hospital. It consists of evaluation, education, and rehab efforts. Phase 2, indicated on this map here in the yellow pin, is outpatient care post-discharge. So that's attending classes on nutrition, stress management, smoking cessation, etc., and exercising regularly. Phase 3, extended outpatient exercise and education program. So as you can see on our map here, we have different colored pins, and the green pins mean that that facility, that location has all 3 phases of cardiac rehab, 1, 2, and 3. The blue is phases 2 and 3. The yellow is phase 2 only. And then the red indicates closed. So if you look at this, we had 14% with green, 24% blue, 35% yellow, and 22% of the 82 sites that replied to our survey as closed. So after seeing these maps, it became clear that there are some CR deserts in both states and could be a contributing factor for CR enrollment and participation being low, in addition to other barriers that Medicare beneficiaries are encountering. So we asked, what are some of the barriers and challenges and successes with your CR programs? We knew that there had been closures of programs in the last few years, and we wanted their input on what the reason or reasons were for the programs to close. As you can see, transportation, the 40 there, is our leader in getting to and participating in cardiac rehab. No shows and cost, lack of insurance are number 2 and number 3. Followed by enrollment is cumbersome for the facility. It's cumbersome for the patient. And then provider buy-in that is so needed for cardiac rehab. And due to that, they don't refer their cardiac qualifying patients to a cardiac rehab program. Now, there were some other additional barriers that were given to us, and those are that patients feel they don't need to attend CR. They think that they can do their activity unsupervised and on their own. The hours that CR is offered will entail the participant missing work. And even though these were, could be 65 and older, they're on Medicare, a lot of them are still working. The patient's health is poor, or they have too many comorbidities that limit their ability to participate. We also heard lack of staffing in the hospitals for the cardiac rehab program. And then one of the big ones was that there was no MD or DO to supervise the CR program. We're going to have a little bit more to come on that here in just a second. So when we looked at our successes, we heard that care coordination is one of the biggest things that is a success for people attending CR and maintaining their enrollment. So the referral process is so important. One of the tips is to make it automatic in your EHRs. Also involve your community health workers to do follow-up, especially when people aren't attending or are missing their CR sessions. There's a lot of barriers that community health workers can help when people are encountering that, especially in minority populations. Find a provider champion. Finding that provider who can advocate for CR with their peers as the greatest predictor of participation in CR is the strength of the physician's recommendation. And then flexibility with CR, knowing the days and times. Sometimes you need to have some evenings for those people who are working during the day. Having a small class size, better ability to individualize the CR experience, and then your community knowledge and promotion. And then one of the best things that has recently happened is the wonderful news that went into effect January 1st of this year, that the MD-DO supervision changed to allow nurse practitioners, physician's assistants, and clinical nurse specialists the ability to supervise CR programs. Now, still at this time, they cannot order CR, but they can supervise. And as always, you want to check with your state's regulating bodies for NPs, PAs, and CNSs to make sure there aren't restrictions in place for these providers to do oversight for programs like cardiac rehab. So what are our next steps after we collected our data? If you look there in box number 1, we're going to provide to 211 directories in each state the contact information we gathered for the open CR programs. And then they can be contacted by 211 to see if they would like to have their names in the directories and the phases that they offer. And this will definitely help care coordinators use the information when making referrals to outpatient CR programs. The second step is to provide technical assistance to CR programs that have closed and would like help reopening, specifically using the Cardiac Rehab Change Package by Million Hearts, which I'll show you that resource in just a second. And then third is continue to spread awareness and help to increase CR underutilization by showing the value CR provides to help patients live healthier lives with their cardiac diagnosis. All right, and so this is the Cardiac Rehab Change Package, the second edition that has been put together by Million Hearts, and that link will be put into chat. It was developed in partnership with the American Association of Cardiovascular and Pulmonary Rehabilitation. It includes a listing of process improvements that CR champions can implement as they seek optimal CR utilization. It's composed of change concepts or key drivers to to develop more specific ideas for change that leads to improvement, change ideas that are actionable for changing a process, tools and resources that are evidence or practice based and can be adopted to improve CR utilization at your organization. If you haven't explored the CR Change package, please check it out. You won't be disappointed. It's very well done. All right. Well, thank you. And if you have questions, please save them for the end of the 3 presentations, and I'll be here and glad to help answer any about our cardiac rehab environmental scan. So now we're going to transition to Stephanie Hansen's recorded presentation. So give me just a second to get that up and going. And we will go here.
Hi, my name is Stephanie Hansen, and I'm a registered nurse and the program coordinator for the Cardiac Ready community. I will refer to it as the CRC throughout my presentation. I am contracted with Great Plains Quinn, but I work for SDFMC and have partnered with Department of Health and the Cardiovascular Task Force. Today, I would like to give you a brief overview of the CRC program and what it means to have your community become cardiac ready. My focus is on my work in South Dakota. However, this is happening in North Dakota. I will provide the contact information for North Dakota. The mission of the Cardiac Ready Community designation is to help communities evaluate their readiness for cardiac events. It includes evaluation, planning, and development of new awareness, prevention programs, CPR and AED training, and AED location information. The CRC program runs through a partnership of the South Dakota Department of Health and the Cardiovascular Collaborative and a volunteer group of South Dakota medical and public health professionals, and support from the South Dakota Foundation for Medical Care. Since 2017, the South Dakota Cardiovascular Collaborative has been working to improve the quality of life for all by preventing and managing cardiovascular disease and its associated risk factors. In 2018, the Cardiovascular Collaborative initiated the CRC program. The CRC program focuses on advancing health equity, optimizing health through chronic disease prevention, improving response to acute cardiovascular incidents, and supporting disease management. The CRC program promotes the American Heart Association chain of survival, which can improve the chances of survival and recovery for victims of cardiac events. So, are you ready? Are you ready to be empowered, be prepared, be more confident, be ready to save a life of a neighbor, a friend, a family member, or any individual in your community? The Cardiac Ready Communities program focuses on educating, equipping, and empowering local community members to be better prepared and more confident in helping a patient experience a cardiac event before the EMT or ambulance arrives. The South Dakota Department of Health encourages and promotes community awareness of the potential for saving the lives of sudden cardiac arrest victims through the use of CPR and increased public access to defibrillation. Bystanders recognize the symptoms of cardiac arrest and call 911 immediately. Early hands-only CPR buys precious minutes until a defibrillator is available, increasing the chances of effective defibrillation. Early defibrillation is the most critical link in the chain of survival. The first 3 links in the chain of survival are also the most important and happen within your community. That's why it's important we get communities involved in the CRC program. All 6 links have been documented to increase survival rates for the cardiac arrest victims. So think about this. If someone in your community suffers a sudden cardiac arrest tomorrow, how likely will they survive due to rapid access to life-saving treatment? How many residents and public safety officials in your community can recognize the symptoms of cardiac arrest and know how to help? Do all of your buildings, auditoriums, and meeting areas have adequate emergency response plans? How many public AEDs are available and ready in an emergency? Most communities won't be able to answer these questions confidently. So again, the importance of having them become a CRC. I know a lot of us live in rural South Dakota. I think about if I had a cardiac event in my grocery store, are they going to know where an AED is or to start CPR before help can arrive? And in the rural setting, it can take up to 30 minutes for an ambulance to arrive, depending on location and weather. So the first step in the application process is identify a champion who will lead your designation efforts. The champion will act as the go-to person to help other members articulate and achieve the requirements to become cardiac ready designated. The lead organization and key partners will help gain community buy-in. Examples are, we look towards our local EMS, law enforcement, fire department, a cardiac arrest survival family member, faith-based groups, youth organizations, school members, community volunteer groups, business communities. The second step is we want to review the requirements in the application form for your community to achieve the designation. Gauge where your community has already placed efforts and identify where additional work is needed. Many communities find that programs are already in place that achieve some goals. Work to form a strong partnership and identify ways that you can improve what has already been done. Grant money, donations, and other special funds are often available for volunteer organization and public programs. Next, fill out the letter of intent, and that will get emailed to me. So by completing that letter, you are notifying us, the South Dakota Cardiac Ready community, of your intent. You will have 2 years from the date the letter of intent is submitted to complete the designation process and will earn your first 20 heartbeats towards your designation. The committee can also be a resource as you are developing goals. Fourth step is each community will determine the best possible plan for accomplishing their goals. Examples would be like host a kickoff event, gain interest by having a large public event, train large groups of people in CPR and record this, have someone responsible for locating AEDs and verify they are emergency ready and registered. Produce a map of the city's AEDs and share with the community and develop materials to advertise. Fifth step, submit the final application, again, which will come to me. And then 6, we want to gain recognition. So we want you to celebrate. We want to celebrate your community when you achieve designation. Street signs will be provided to post and will recognize your efforts to have your community cardiac ready. We really just see it just bring together the community. And lastly, it's essential for the community to continue efforts to sustain their plan for readiness for cardiac emergencies. Designation is good then for 3 years. So there are 5 focus areas, and each community must earn heartbeats within each focus area. The 5 focus areas include early access to emergency care, early defibrillation, AED identification, early advanced cardiac arrest care and post-cardiac arrest care, community heart health, and sustainability plan. I want to point out that these 5 focus areas are all on the Department of Health website. We have it laid out in our application guide. I will not go over each step, but there will be a YouTube video to walk through this. And that should be available soon. And again, that will be on the Department of Health website. And that is where then we will just walk through each focus area so you can see how you can earn your points and it'll be pretty self-explanatory, but that's why we are here for you to walk you through it also. So you may be wondering what heartbeats are. Heartbeats are points. Every activity and step your team identifies and plans will have a point value. Points can vary for each part of the application. You should calculate heartbeats based on what you know about your community in the planning stages to gauge the following steps and how many you will need to become designated. There is a minimum number of total heartbeats required for designation. There are minimum heartbeats required to come from each focus area. So one focus area being the CPR, AED training, AED identification, new training events, and a minimum number of public AEDs to be identified. All numbers listed in the chart above represent the minimum requirements within these categories. An example would be like to get 10 heartbeats that you could be awarded if the community would come up with a city area map with all public access AEDs identified, promoting awareness to the public, and then provide a copy of the public access map throughout their community. Again, this is all explained in the application process. That was just example to share with you. So the sustainability plan. As a community is getting close to designation, it's important the team works together to have a sustainability plan. This is where final heartbeats are obtained. Heartbeats are awarded to having plans in place to continue over the 3 years. Points are also awarded for having continued presence at community events, such as 5Ks, health fairs, mass CPR trainings are just some examples. The Cardiac Ready Community application is a separate document. It can be filled out as you are earning heartbeats or at the completion using your own records. However, it is recommended that you read the application completely before beginning to know what you will need to document for the final application. We have provided some resources here and will have my contact information available to you. One area to target under the focus area of community heart health would be to promote tobacco cessation. This is a way to earn heartbeats as you build the community awareness on tobacco cessation. This is why I added the Great Plains Quinn change package and both the quit lines in South Dakota and North Dakota that you can reference to help with some of that promotion. I wanted to share a map of North Dakota and the areas in red that are already cardiac ready communities. And the green area is the college campus that has become a cardiac ready campus. North Dakota has done great work already and hopes to continue to grow. We will add the North Dakota contact information if you want to inquire on this in North Dakota. In South Dakota, we have 3 communities that are designated now: Kimball, DeSmet, and Plankington. Mitchell and Iroquois have just signed the letter of intent, so our team is excited to start working with them. Here are some pictures of the CRC designation event in Kimball on August 11th, 2021. You can see their team here included a wide variety of community members, city council members, ambulance lead, business grocery owner, nurse, hunting lodge owner, newspaper editor, and fire chief. The Department of Health does provide the communities with cardiac ready community signs to place upon entering the town. So you can see there what the signs look like. So it's just real exciting, and it's exciting to see how the community from all different areas just come together and make this happen. Here is, we're celebrating DeSmet, South Dakota. So here are some pictures of their designation. And our most recent designation was in Plankington. They have not put up their road signs yet, but this is a picture of the road sign that they will put up. So that's exciting for them also. Next, I'd just like to share a video from the Kimball designation.
And my D's pulling up the video. I'm going to put the link to the Kimball video in the chat for you all.
Here's some pictures of
a few years ago, our first year of running the lodge, we had some gentlemen out trying to train their dogs for dog trials. They're out in our alfalfa field and they collapsed. He died right there in our alfalfa field, and we didn't have an AED at the time. We didn't have anything besides me being able to go out there and do CPR and wait for an ambulance to get out there. And unfortunately, he was, we couldn't do anything. And your hands are tied, and you need more options.
Well, the things we've seen with in the past in our community, in many small communities in South Dakota, is we've have a tendency to not have the care available, the resources available as quickly as we could have, or as quickly as there are in more urban or metropolitan areas. And with those lack of resources, it makes it very difficult when we have a cardiac event or any type of medical emergency to liken the survivability of an individual.
From the time the call comes in from 911 till we've got wheels leaving the shed is more than likely less than 5 minutes, whether it's during the day or at night. The travel distance to some of these lodges is 15 to 20 minutes, 20 miles. And with the roads the way they are this year, that could be up to 30 minutes before we get there. Without this program and them having a defibrillator right there and knowing CPR, that person probably will not have a chance of survival.
When people are moving to town and we're trying to build up our businesses in our community and get people in the school systems, can we take care of their loved ones? Can we in the community make everybody feel safe, make everybody feel comfortable, like make them want to be here and know that no matter whether we have 200,000 people or 700 people, we're a strong community and we can provide, and we need to step up those services to do so.
I guess one of the reasons that it's very important to embrace the Cardiac Ready Community Project is people that had a heart attack years ago might have had a better chance of survival. If we'd had this program and had more people trained, they would have possibly had a chance for survival and still been here to talk about it today.
We're giving everybody a little bit more of a chance, and that to me is exciting.
While Dee's trying to figure this out, we have about a minute left of Stephanie thanking you. And I just want to double check and see if Tim is on the line.
helping
I
to
am here,
improve
yes.
health outcomes,
Okay,
make awareness of
perfect.
heart healthy living, and preparing your community to save a loved one. So is your community ready? We are ready to walk alongside you and make this happen. Just send any questions to my email or put in chat and we will get back to you. Sorry, I could not be on here live today, but you will have my email, and please reach out and I would love to connect with you and go through what it means to get your community cardiac ready. Thank you so much and have a great day.
Okay, Tim, I'm going to stop sharing and hand the presentation over to you.
Sounds good. Thanks, Dee, and thanks everybody for allowing me to join this afternoon. I see a few familiar faces on the call, which is great. Let me just pull up my slides here and we'll go through it. I will mention there's a lot of information in the slides, but I'll make sure the team there has them and everything will be linked to the resources you might need to access after the call. So I am Tim Nicolai. I'm the Senior Rural Health Director for the Heart Association in the Midwest region. I am sitting in Wisconsin where I live, but I cover the Dakotas and then all the way back to Ohio and Kentucky, so 13 states in total, and wanted to provide an overview of our Outpace CVD initiative, which is made up of some components that are some of you are probably pretty familiar with. Real briefly, our organization is celebrating 100 years this year in June, so we're definitely excited about that. You can see the reduction in cardiovascular deaths since 1968, and yet heart disease remains the #1 cause of death in the country and around the world. And our guiding values dictate that we want to continue to change that. And you'll see, when we think about building powerful partnerships, that's what you all on the call and the organizations you work for and the communities you serve represent, those opportunities for us to be a resource for you in the name of improving health. And that's certainly what Outpace CVD strives to do. We have a call to action on rural health that came out in February of 2020. And while that was kind of lost in the shuffle that happened with COVID, we saw many of the recommendations there gain even more utility when we think about things like telehealth as a way to drive healthcare access. When we think about discussions around health equity, we know COVID brought a number of those things to the forefront, even for organizations that weren't previously thinking about them. So would encourage you to check out that advisory. It is linked here. So when we think about cardiovascular disease risk targets and event reduction, we know that if we can bring blood pressure, cholesterol, or A1Cs into control, we can have a significant impact on reducing the risk of future cardiovascular events. And so that's the potential here. There's a lot of information out there about the challenges associated with these things, and I'll show that, but wanted to start us with the potential that we can have when we do follow best practices and activate science, bring that to life into clinical practice. So this is just a little bit of a snapshot of the high blood pressure in the Dakotas. This information comes from America's Health Rankings, is the bar graphs there, and then the heat maps are from City Health Dashboard. Definitely encourage you to check out both of those websites. I show high blood pressure here, but they have similar information on diabetes, tobacco use, physical inactivity, any number of things broken down by similar demographics. So our clinical systems change work, and this is important for all of the work that I'm on our community impact team at the Heart Association. And so my colleagues throughout the country, this is kind of the cycle we try to follow when we're working with healthcare organizations. Today, we're mostly talking about the equip stage of the effort. And so I'll share some of those tools and resources with you. So Outpace CVD, I mentioned, is a new initiative, but really it's a packaging of some prior initiatives that the Heart Association had. And again, you're probably familiar with some of those. Target BP has been around for 7 or 8 years now. Check, change, control cholesterol came a couple of years after that. And even our newest initiative, Target Type 2 Diabetes, which is a joint effort with the American Diabetes Association, I think it's probably hitting like our 4th year now. But all 3 of those together, they exist independently, but certainly roll into that overall Outpace CVD. You can see some of what the framework for those is, that we want to provide clinical guidelines and protocols, offer resources you can use as staff, but also reshare with your patients in some cases, connect you to other partners doing the same work. A lot of this does point to awarding achievement for healthcare organizations that are demonstrating or achieving clinical excellence. And the nice thing is that's based on data submission that many of you are probably already doing already, you and or the partners and organizations you work with. And you can see some of the measures that are captured when you participate in these programs. So in the Dakotas, we had some great engagement last year, and you can see that out there. So congratulations to Spectra Health up in North Dakota. They did a fantastic job engaging in all three components. And then we had All True Health up there and Sanford Health across the footprint that participated in our diabetes and participated in all three programs as well. So kudos to those organizations. My hope is if we do a similar presentation next year, it'll be even more crowded on a slide like this as we see some additional spotlighting done. So time is limited here today, but wanted to provide at least a brief snapshot of some of the tools and guidelines within each of the three programs for you all. Target BP is based on the MAP framework, which was developed by the American Medical Association out of a project at Johns Hopkins University that said, if we're going to control blood pressure, we need to do these three things. Measure blood pressure accurately every time, act rapidly to treat and diagnose that, and then partner with patients and their communities to promote self-management, monitoring, and adherence to treatment. And so Target BP seeks to close the evidence gap that exists between science and practice in many cases. So you'll see, again, just a snapshot here, there's a gap. Only about 10% of clinical blood pressure readings meet all the standards for accuracy. So Target BP works with organizations to train staff annually on proper technique and increase the use of automated validated blood pressure monitors. There's a gap. Treatment intensification with a new class of BP medication, which can have a dramatic impact on uncontrolled hypertension, only occurs in about 12% of visits. So Target BP and our organization works with you all to establish treatment algorithms that can set that standard for treatment intensification and incorporate things like team-based care. When we think about partnering with patients, again, a gap that patients are often uninformed about their blood pressure numbers and they have uncertainty about what to do next. And so a comprehensive SMBP program can be part of that solution. And we've been fortunate enough to work with a number of organizations in the Dakotas and around the country, certainly to that end. I'll also mention real quickly on the community side, we do have a grant opportunity open till the end of this week for libraries that want to become community hypertension hubs and provide an access point for people to check their blood pressure. So we've got a couple of applicants from the Dakotas, would love to have a few more. And this is linked when you get the slides to that application and would encourage you to share that around in your community. Can also be part of the Cardiac Ready community plan for you. A few of the resources, I won't belabor those, but you can see there's tools about staff training, there's policy and procedure templates, there's infographics to hang in the exam room around proper positioning in English and Spanish. We've got sample treatment algorithms. We've got that SMBP device accuracy test has been really useful if patients have their own device at home and you want to see, like, is this really worth their time and energy in using it? That can help you check its accuracy against your monitors in the clinic. Again, provided you have a good degree of confidence that they're meeting the standards themselves. Moving to hyperlipidemia under check change control cholesterol. Again, we think about that care gap, that only about 17.1% of ASCVD patients. The ASCVD risk calculator is a predominant feature within the cholesterol guidelines and lots of resources around that within the check change control and cholesterol environment. We see that only about 17.1% of patients had any lipid lowering therapy intensified over the last 2 years. And I don't have it in here, but even among patients who had already experienced a stroke, there were some pretty significant gaps across the country in terms of the rate at which statins are prescribed. And so the data we capture here is around what is the rate of statin prescription as indicated by the guidelines. We can see here too, within this study of over 600,000 patients, many of them were not getting high intensity statin. Only about half, or I'm sorry, only about a quarter were getting a high intensity statin. Half of them were not getting any statins. And the odds of that varied based on some of the constituencies that were out there. In some cases, rural areas lag behind. Some of the newest data shows that in other places it might be a little bit ahead of the national average, but definitely an opportunity for improvement for most organizations. Or if you're one that's doing really well here, might be an opportunity to shine a light on that and help others learn from your success. Some of the resources there, again, some of these are both patient-facing as well as provider and staff facing when we look at like the clinician pocket guides, for instance. So I would invite you to check those out. Type 2 diabetes, again, I mentioned this is an initiative with the American Diabetes Association, which I think just makes the resources all the more robust. And we've had some great webinars lately on the new standards of care in general, as well as how they relate specifically to cardiovascular health. Really, the stated purpose of the initiative is to make people aware, both providers as well as patients and the general public, that heart disease is the #1 leading cause of death among patients with diabetes. And we need to be aware of that and treating it accordingly in clinical practice. One of the things, just as an example, so with all of our programs, organizations who participate and seek recognition are asked to attest to certain things. And one of the new focus areas for the type 2 diabetes program is around kidney health and how often you evaluate that to help us inform where there may be gaps across the country. Your recognition isn't based on that. We're just using it as a checkpoint for your own organization and to get that landscape analysis across the country. And you can see this chart just came from CMS's new Rural Health Disparities Index for Medicare Advantage participants. And you can see, looking at that kidney health evaluation, there's a significant gap between urban and rural settings across different racial and ethnic demographics, that urban areas are far more likely to have that kidney health evaluated. And so this may be a place where some work can be done across the Dakotas to help improve practices and ultimately improve patient outcomes. Again, a set of resources. Some are kind of patient focused, some are clinical and physician focused and staff focused. There is that webinar about the standards of care that is linked here if you want to access the recording. On the right-hand side there, you see those 2 images with the 3 people. Those are some e-modules designed to help the layperson kind of walk through a conversation around diabetes and its connections to cardiovascular disease. We have similar ones for hypertension. Those are available in English and Spanish. A lot of like community health workers and others have used those to facilitate those conversations and just help give patients a place, patients and or their family members, a place to circle back and get refreshed on some of the information that they need to keep at the top of their mind. So a few things, if you're looking to engage with Outpace CBD, at the individual level, certainly would encourage you to use these materials and resources to educate yourself, your colleagues, your patients, and your family and friends. Chances are you all know somebody who's got hypertension, unfortunately, or hyperlipidemia, or maybe pre-diabetic. And so we hope those tools and resources can help on that individual level, if nothing else. But for those of you that work for healthcare organizations or support healthcare organizations, what are those opportunities for process improvement? Are staff being trained annually on blood pressure measurement? What type of monitors are being used in that clinical setting? Are you using and maximizing the opportunity of the ASCVD risk calculator to help inform that patient-provider conversation? Are you looking at possible gaps around diabetes, like things for screening for kidney health? And then certainly would invite you to seek recognition by registering for one or more of those components, with plans to submit, again, that aligned data by the May 17th deadline. Just that quick note there on the bottom. You can do this without ever talking to us, but we are happy to provide support and learn from and alongside you as you work to find those opportunities for improvement. I did want to mention also, we do have a special opportunity right now around telehealth that's there for outpatient initiatives supported by the Helmsley Trust that I know many of you are well familiar with. We're looking for about 25 outpatient clinics across the country. There's some funding attached to that. There's some quality and quarterly collaboration calls to connect with experts. We do ask for some basic data to be submitted as part of that process. And we'll be looking to develop strategies and quality frameworks to improve telehealth care delivery. So there's no firm deadline on this, but I would definitely encourage you to express interest via that form or by reaching out to me as soon as possible. Our hope is really to have those 25-ish clinics up and running, sometime this summer so that we can maximize the runway for them to engage in those collaboration calls, connect to others, and build out some of those lessons learned. Also, real quick, here are some other opportunities for professional education for those of you in healthcare. You see the hypertension certification, the telehealth professional. Some of those are free. Some of those have some costs associated with them, so feel free to check out the differences there. Dee had shared that there would be some folks here from senior living and nursing care facilities. So I'm not the expert on it, but if you're looking for certification or resources in that environment in particular, that little logo will take you to some more information on that, and I can certainly connect you with colleagues in that space. There is my contact information. I'm happy to certainly answer questions now, along with anyone else who is getting questions. You're also happy to or welcome to reach out to me subsequently. And if you'd like, I do have a rural newsletter that I know some of you all get, but if you'd like to be added to that list and keep up to date on new tools and resources and grants, that is a good place to start. And with that, I will turn it back to Dee and the team to guide us through the rest of the call.
All right. Well, thank you so much, Tim. That was very informative. So I really appreciate you taking the time to be on the call today. So are there questions?
Thank you, Dee. There are not questions that I see, but don't be shy. If you have a question, take yourself off mute or place it into the chat. You can find the chat icon at the top of your screen, and we can either pass your questions on to Dee or Tim, or maybe someone from the cardiac ready communities in North Dakota or South Dakota. I guess I'll just reiterate that we will be sending the recording, and we will be sending the slides from all three presenters today, because a lot of the resources that Dee, Stephanie, and Tim mentioned are all included and embedded in those presentations. So we'll get those into your hands by the end of the week. And I still don't see any questions. We'll give it another minute before we close out the session. Just a reminder, as an attendee, we'll send you a certificate of participation. You can submit that to your accrediting body for continuing education if you'd like. We are an approved provider of continuing education with the North Dakota Board of Examiners for nursing home administrators, as well as the South Dakota Board of Nursing Facility Administrators. So we'll send you a certificate after today's session as an attendee. Kelsey's going to put the link to the evaluation form into the chat. If you have a minute and you can give us some feedback on today's session, that would be wonderful and very much appreciated. We will share your comments and your feedbacks with our co-presenters today. Evaluation is in the chat. I guess I'll ask one more time. If anybody has any questions, please take yourself off mute or add it to the chat. All right, if not, thank you, Dee. Thank you, Tim. Stephanie's vacationing somewhere nice and warm and sunny, but we thank her as well and her collective team in South Dakota for the good work being done. So thank you, everyone. Have a great day, and we'll talk to you next time. Thank you.
Thank you, everyone.